Good evening, good evening, good evening, and thank you for joining us here on blackdoctor.org. This is our monthly series called Seeing Eye to Eye, where we talk about all things related to our eye health, and that is in partnership with the Children's Vision Equity Alliance, as well as our other partners at Prevent Blindness and the National Eye Institute. So I want to give a shout out to our partners that puts on this fantastic series that we've been doing now for it's close to 2 years. I think we got to look at the numbers on that. We just see how long we've been doing this, but we have done a number of shows on glaucoma and retinopathy and eye injuries and everything in between, surgeries, cancers, everything that you can think about. And tonight is the first show that we've done about this particular topic. So I want you to stick around because you're going to hear something new and exciting this evening, and that is retinopathy of prematurity. Okay, I'm gonna let that sink in for a minute. Retinopathy of prematurity. Well, what is that? Well, we're all going to find out tonight because we've got two fantastic experts here with you this evening. They're going to give you what it is, what you should be looking for, why it is, and what are the treatments particularly for your child. Because I think we all know what prematurity is, and we'll just deal with the retinopathy part. So we'll put it all together and make it make sense. Couple of things I need for you to do for me before we meet our fantastic guests. And that is number one, let us know where you're watching from. We'd like to know where people are watching us from all over the country, all over the world. So if you would drop that in the comment section, we'd love to hear about that. Number two, if you know somebody that needs this information, please tag them or share this on your page. I understand if you know somebody that's a new parent that's about to have a child, anything like that, there will be some great candidates that get this information to add to those things that they're already worried about with their child. But that's okay, because we're going to help them not worry about that when we're talking through tonight's program. Because you're going to say, I saw this great program and I'm equipped to deal with if we have to deal with that with our child. And then number three, if you have any questions throughout tonight's broadcast, drop those in the comment section. We'll try to get as many as we can asked and answered. Most of them will be answered. They've got a great list. We've got a great list of questions that we'll get it. But if you have any questions, please drop those in there and we'll try to get to as many as we can during the hour that we have with you tonight. Finally, I want to say before we get to our guest is the information that's going to be presented tonight is for informational purposes only. If your child it's already under treatment, or if you are under treatment, if you're under care of a physician, please do not make any changes to that treatment plan. Discuss what you've learned tonight. If you learned something different tonight, discuss that with them before making any changes or adjustment, because they haven't read your child's chart, they haven't done anything, so they would not be able to give you sound, independent advice. This is kind of a general advisement, but you need to have those conversations with your provider. We good? All right. I know you did not come on here to hear me drone on about all of this other stuff. Again, give yourself a shout out and let's get to who our guests are. First off, we have Dr. Tiffany Gladys, and she is an associate professor at the University of Missouri, Kansas City, and serves as the perinatal neonatal psychologist at Children's Mercy Hospital, Kansas City, supporting families in the Fetal Health Center, the Neonatal Intensive Care Unit, and the Neonatal Follow-Up Clinic. Dr. Gladys is also the medical director for the Office of Equity and Diversity at Children's Mercy. She has a lot more that she's doing, but I'm going to give you I gave you the Reader's Digest version. You see all of those big fancy words. That means she knows what she's talking about, and we're happy to have her with us this evening. Our second expert is Dr. Charity Grandis, and she attended Baylor College of Medicine for her medical training, graduating with honors. After medical school, Dr. Grandis had the privilege of spending a year in the Methodist Hospital's Transitional Year Residency Program. She then moved to Dallas for the Ophthalmology Residency Program at the University of Texas Southwestern Medical Center. After 3 years in Dallas, she returned to Houston to serve in the fellowship program in pediatric ophthalmology and strabismus at Baylor College of Medicine and Texas Children's Hospital. Woo, say that 5 times real fast. Dr. Grandis was motivated to stay in Houston and work with the people in a city she loves, and she is pleased to practice ophthalmology at Houston Eye Associates. So she's got some other board associations and some other great things that she has done. She was fantastic in high school too. I'm just letting you know because I read the whole bio. But just to say that, all of that being said, we've got two of the best experts that you can have on this topic tonight. So welcome. Thank you so much for my diatribe there.
Thank you.
All right, so let's get to the nuts and bolts of this whole situation. We're going to start with you, Dr. Lanner.
Mhm.
I've said the words, but we need to know what it is. What is retinopathy of prematurity?
So retinopathy of prematurity, for short, it's ROP. It's a condition where abnormal vessels grow in the back of babies' eyes, babies that are born premature. So babies that are born premature of low birth weight, they can have this abnormal vessel growth that can lead to retinal detachment and severe vision loss. And so this is why it's very important that we do screening exams for these babies in the NICU and as outpatients.
All right, so abnormal vessels for those babies that are premature. Okay, so what about the terms that parents will hear related to ROP?
Also, we describe retinopathy of prematurity by its stage or its extent of growth, and then also by something called plus disease. So the first of all, the extent of ROP. Usually, the retinas in babies or just in people start developing from the optic nerve, though they grow out from the optic nerve, usually at about 16 weeks gestation. And so we talk about there being a zone 1, which is centered around the optic nerve and twice the distance from the optic nerve to the center of the retina going out. And then zone 2 is something that parents usually hear. It's the ring shape around that first circular zone that extends completely nasally to the nasal ora serrata, which is the outmost part of the eye in the retina or in the back of the eye. And then there's a crescent area just beyond that going temporally, which would be zone 3. So zone 1 is closest to the optic nerve, zone 2 just outside of that, zone 3 furthest extent. So we describe ROP based on that, zones, and then stages. So how severe the ROP is. So we have a stage 0 with no retinopathy of prematurity, 1 with just a line, a demarcation line, 2 would be a ridge with some width and height to it, and then 3 would be vessels growing off of that ridge, 4 would be a partial retinal detachment, 5 a complete retinal detachment. And then finally, we talk about plus disease, which is looking inside the back of the eye around the optic nerve and seeing how tortuous and dilated the vessels are. So we have an image that kind of describes what plus disease looks like, but it's really a continuum of vessel dilation and tortuosity that tells us maybe how quickly the ROP might be developing.
All right, so I told y'all she was an expert, right? Y'all just heard that. Okay, so we and truth be told, the audience has been prepped a little bit because we've done 2 series on retinopathy, but diabetic retinopathy. So I think there are some people that are watching that are familiar with what kind of retinopathy is in a general sense. And so what we're talking about in this case is it's those children, those infants that are premature and developing this distinct form of retinopathy. So, we got what that is, and then we know that there is stages and zones, right? So those are the 2 things that you're going to hear as a parent. You're going to say, okay, what zone is it in, and then what stage, right?
And then this question of plus disease, yes or no?
Okay, so those are the 3 things. So parents, you hear that, and do they give you like a combination that's going to be in this zone at this stage? Would they do like that?
So we say it's this zone, this stage, yes or no to plus disease.
Got it. All right. So look, y'all remember to write that down. All right. So what causes ROP and who's at risk? And I'll do the follow-up is that do all premature babies get ROP exams?
Yeah. So the babies that are at risk are the ones that are 30 weeks and less or 1,500 grams and less at birth. And so not all babies that are born premature get this exam. It would be those, okay, that are always included. And then any others that might have comorbidities that the neonatologist decides are worth them having an eye exam. what causes it, there's external factors. So um, you can have oxygenation, oxidative stress, light, internal factors. There's different proteins made inside the eye that can cause ROP to happen, but usually it's associated with low birth weight and prematurity and fluctuation in oxygen levels or high oxygen early on in life.
Okay. So what do parents need to know? Those babies that fall into that range where they would get examined for
Mm-hmm.
P, what do parents need to know about the eye examination itself? Do the child gets put to sleep? Where do they perform? Can the
Mm-hmm.
parents stay in the room? All of those different things.
Yeah, so the parents need to understand that the exam's necessary, first off. They don't have to be put to sleep. The babies typically just get a numbing drop in their eye, and they have some dilating drops that are given, which is usually something called cyclopentolate and phenylephrine, some combination of that. So the pupils are dilated, and what happens during the exam is that a lid speculum or a device is used to open the eyelids, and the ophthalmologist has another instrument to move the eye from side to side. The ophthalmologist wears a light on their head, so I usually come in with a light on my head and I look at the baby's eyes. It takes maybe about 20 seconds, 30 seconds to do the exam. The baby feels a little uncomfortable, but I don't think that it's painful. But the light's bothersome. The baby's eye is being moved from side to side. And the exam's it's very necessary. Um, the baby doesn't have to be asleep. We do the exams in the NICU, or in the office if the baby's been discharged. And the parents can stay in the room. What I do is just always offer that as an invitation. I invite them to stay in the room if they want to, or step out if they want to. It's whatever the parent feels most comfortable with. But I warn them that the baby might cry.
Yeah, it's a child. Whenever you get a child and you start forcing a child to do things, they get there'll be some emotional discomfort. I think maybe that's more the issue, and we're talking about that. So you're right. There may not be a lot of physical pain, but that's just I'm in a situation that I don't want to be in, and
Mhm.
that is moving to our psychologist, right? So we're talking about emotional pain versus physical pain.
Mhm.
So, Dr. Gladys, when you're there, what is the parent's experience when they have a child in the NICU or the neonatal intensive care unit? I want to use jargon, the neonatal intensive care unit, otherwise known as the NICU.
Yeah, I mean, I work in a level 4 NICU, and what that means is the highest acuity of conditions that are being presented amongst the babies. And so it is definitely a critical care situation. And for many parents, their experience is whatever you can imagine your worst nightmare is, that's what's going on for these families. When we think of having a baby and bringing a life into the world, no one imagines having to have their baby in the NICU. But then that is the reality for these families. And so it really can be quite overwhelming. There's lots of providers that they're meeting, nurses, people caring for their baby, which can be overwhelming. There's lots of noises, alarms, sounds going off at their own bed space, at other babies' bed spaces. And it can just feel very traumatic. It is very traumatic. And it's a very triggering environment as well, because often you feel, you have no control. There's lots of things that are changing rapidly. There's lots of medical words that you're trying to learn and comprehend in order to understand what's going on for your baby, and in order to make decisions moving forward about their treatment. And so it is a lot for parents. It is traumatic, to say the least.
So, what kind of support do you provide, or what kind of support basically do parents need when they have a child that's in the NICU? And what are some of the parents' biggest concerns when it comes to that experience?
Sure. One of the things that we know from research is that babies do best in their physical, social, emotional development when they have a healthy, secure attachment with their primary caregiver,
Mm.
which could be mom, it could be dad, it could be grandma, it could be foster parent, whoever that main adult is or adults caring for the baby. And so my job as the NICU psychologist is to be the support to the parent so that they can be in the best emotional and mental state that they can in order to be that secure base for the baby. So I always like to talk about it as a parallel process. Like I'm making sure the parent is well so that the parent can make sure the baby is well. And so what that looks like in a practical sense is usually addressing three main issues for parents: depression, anxiety, and post traumatic stress disorder, which are all very normal and natural responses to experiencing a trauma. And so I help parents kind of process everything that has gone on to get them in the NICU and then the trauma that continues as they're in the NICU. And so a lot of coping skills and helping empower them to address certain things with the medical team or even how to just interact and engage with their baby. Because if they have a 1,500-gram baby, they're likely going to be in an isolate. And so there are certain times when they're able to hold and when they're not. And we know that that connection with the baby, the holding, the engaging, the doing the diapering is all very vital to that baby's foundational brain development. So helping foster and encourage that between the parent and the baby is another part of my role.
Well, I try to make things as everyday, try to equate something to everyday life. And so it's like, so parents, what she's talking about is like, baby might be USB. You got to be USB so y'all can connect in order to get that charge. If you're USB and the USC, is not happening, right? And so we've got to make sure that you're both, whether it's one, whoever the primary caregiver is, you're in an alignment in order to be able to be the best emotional support for that child, because they're already going through something, being low birth weight. I'm sure there's a lot that's happening around them. So there's got to be a stable foundation for that emotional develop to occur naturally. Is that what I heard you say, Dr. Gladys?
That was beautiful. You did a good job.
Look, everybody knows about the USB and USC problems. Okay. I got a problem with Apple about all that foolishness. Keep changing on me. All right. Anyway. All right. So final question, then we're going to come back to you, Dr. Granite. Once a family gets a diagnosis of ROP, what are the biggest challenges parents talk with you about?
I would say the two top ones are grief and guilt. So, and this is not just for parents of babies who have an ROP diagnosis. And most of the time, ROP is not the only thing that they're dealing with. You know, when baby's born really early, there are a lot of other potential diagnoses or prognosis that are a potential for that child. And so the grief of the experience that they had hoped to have with the new baby is now gone. And so really encouraging parents to allow themselves to grieve, because sometimes we try to be really strong and hold it together, but we know that it can be healthy to have a normal human reaction to a traumatic event. And then I would say guilt is often very present. Parents feel like, what did I do to cause this?
Right.
Even when we know there's nothing that they did. Babies sometimes are just born early. We know that there is an increased risk for Black women to deliver early because of a host of different medical conditions, and then just weathering of dealing with some of the toxic stress that exists in our society when you are a Black person. And so even when parents know there's nothing they did to cause it, that guilt is still ever present. Right. And so really helping them get to a place where they can choose to release that guilt Because when we feel guilty and someone says, oh, don't feel guilty, you didn't do anything, oftentimes that doesn't necessarily change the emotion that we're experiencing. So I don't tell parents that, but what I do tell them is that I hope you get to a place where you choose to release that guilt, because it's not serving the situation. It's just, I like to use the visual of like holding a heavy bag around in an already difficult situation. It doesn't make things easier. It only makes things harder. So I would say those are two of the big kind of things that come up for parents, especially after getting that diagnosis or any other diagnosis in the NICU.
Yeah, it's funny. That made me think about when I was in grad school, going to counseling, and the counselor said to me, there's two types of knowing. There's rational knowing and emotional knowing. And so I think that's what you're describing there, is parents may rationally know that the doctor tells them, everybody tells them, don't feel guilty. There's not anything you did about it. So rationally, they understand that. But emotionally, they're still not connected to it. And so that's what that grieving process is for, to allow them to connect to that emotional knowing, to where they can get beyond it. Because just trying to convince yourself rationally is maybe not be enough to get past those feelings of guilt.
Absolutely.
All right. So we talked about what it is, Dr. Grandis. We talked about the diagnosis and the state. You got the stages and all different types. How do we treat it? And is it different for each one of those stages that you talked about, each one of those zones that you talked about? And, and how what's your line of demarcation in terms of who gets treated, or do some babies just grow out of it naturally?
Well, so most babies end up just growing out of it. The ROP will involute spontaneously, just disappear. And so that's about 90%. So about 10% of babies need treatment, okay? And 10% doesn't seem like a lot, but it's very severe if they need treatment. So what we offer is Avastin injection, so a medication that can be injected inside of the eye to halt the progression of that retinopathy. Or there's laser that can be given, so a laser that's applied in the back of the eyes. And the Avastin injection is usually given with a numbing medication first, or some sedation, but that's done in the NICU. And the laser is typically done in the OR with the baby asleep. Now, there are some practitioners who do it in the NICU, but in my practice, we do it with the baby asleep. So the babies that end up needing to have Avastin or laser are the ones with type 1 retinopathy of prematurity. So those are babies that have, okay, so we're going back to zones and stages again. Right. So babies that have ROP in zone 1, okay, with stage 3 end up having usually an Avastin injection, zone 1 or early, a more posterior zone 2, with stage 3, or if they have plus disease, that vascular dilation and tortuosity again with any type of stage, then they'll end up having usually an injection of a medication. And then type 1 ROP is also ROP that's in zone 2, either stage 2 or 3 with plus disease. So we'll treat then too. And that could be either with an Avastin injection or with laser that's delivered to the back of the eye. And really that depends on what the institution has, or if the baby's being seen in the NICU versus its outpatient at that time. And, it depends really on how much growth of the retina has happened already, and what's available to the practitioner at the time.
Yeah, I was sitting there thinking, like, when you're talking about major cities, like I'm in Atlanta, you probably have lasers available to you in a regular basis with multiple hospital systems. But if you're living in a rural area where there's not as many opportunities, you might have to make a decision just to be an injection only, or have to have that further transferring a premature child to a larger facility, a larger city where they could get these procedures done. And so those are some of those challenges, Tiffany, Dr. Tiffany, that you have to kind of walk parents through when they're talking about the treatment plan. So, and Dr. Charity said, all right, well, here's your treatment, here's your options. And then Dr. Tiffany says, okay, well, how do you deal with that options if there might be some insurance challenges, some payment challenges, all of these other challenges, socioeconomic challenges that could pose even more of anxiety to the situation. So how do what type of conversations are you having? And what are some of the major issues that you address with families of babies with ROP?
Yeah, and I would add to that from a psychosocial perspective, my hospital is a regional hospital.
Mm.
So we serve everybody from St. Louis all the way to Denver. We're the only level 4 NICU. And so our catchment area is pretty big. So sometimes families are 3 or 4 hours away from home. Sometimes they have other kids at home. Sometimes they're a single parent and they're not able to be at bedside. And so all of those other factors start to play into their already difficult situation. That would be hard if they lived down the street and had 2 parents and, incomes and no other kids at home. And so the decisions that parents have to make are under a lot of stress.
Right.
And so one of the things that I think I really value at my institution is that there is a high value of psychosocial support. And so not only do they have myself as a psychologist as a resource, but we have child life and we have chaplaincy, we have a palliative care team, we have a parent on staff, and all of these people are a part of a team that's there to help these families make hard decisions. And I really value our parent on staff because they offer a different perspective than the medical staff, because they are a parent who themselves has had a baby in the NICU and had to make a lot of these treatment decisions. Even if they may not have had the same, exact scenario, they know what it's like to be a parent in the NICU in a way that's different than I do as a psychologist or as their neonatologist may know. So I feel like, have created a really good system to help parents kind of work through some of these challenging decisions that they have to sometimes make.
Yeah, I do want to follow up with that. I'm sorry, but I guess my background is kicking in. So, in that space, how much do you encourage parents to talk about it and to share? Because I know sometimes when we hold things in, that becomes problematic. We have anxiety, stress, cortisol releases. We talk about all those. Blood pressure goes up, and we know all of the different things that can happen with elevated blood pressures. So,
Yeah.
how much do you encourage parents to talk about that, to talk to, whether it's other family, whether it's a friend, a confidant, something like that, so they can kind of relieve themselves of some of that burden to help lower the stress level that could come with having a child in the NICU?
Yeah, I think honestly, people often ask me kind of, what is the thing that you do to help parents? And often it's not something really complicated or super psychological. It's being present with them and allowing them the space to talk through the things that they're dealing with. And so if we were to get super psychological, that would be considered a narrative therapy approach. But one of the things that we know is that when people experience trauma, getting to talk about it helps them gain some mastery over the trauma rather than the trauma having mastery over them. And so oftentimes I am able to just invite a space for parents to tell their story from an emotional connected place rather than just the medical parts of it. Like they've told the medical team, what happened to cause them to get there or what they may have experienced. But when they're talking with the physicians, they're not talking about, well, what does this mean for you? Or the fact that they lost the last baby that they tried to have, and now they're in the NICU, and this just feels like another disappointment. And so being able to get all of that out, because trauma lives in our body, if we don't get it out, it does have an impact on our physical well-being. And so I think part of the gift, not just in the service that I provide, but in the service that all of those psychosocial people provide, is creating space for people to get it out, to tell their story.
Absolutely. All right. Thank you for that. So Dr. Granis, what are some of those questions? I know parents have a lot of questions when you say when they child gets diagnosed with ROP. What are
Mhm.
the questions they ask you about the diagnosis, and what are some of those questions they ask you about the treatment?
Yeah, so they usually ask, what is this going to mean? Is the baby going to need to have treatment? How long will the baby be followed afterwards, after the treatment's given? Um, the questions about the treatment would be, what type of risks would be involved with having the treatment? Would it hurt? And so I let them know that, follow up with us is a long time afterwards. If the baby needs to have an injection of a medication, which is, typically the first step these days in a lot of forms of type 1 ROP, we follow the baby through 65 weeks, and maybe I think about 25% might have a reactivation of their ROP, where the ROP starts happening again after treatment, usually a couple of months after. And so if that's the case, then we talk about maybe there being a need for retreatment. Um, and you know, so we'll follow them for a while through 65 weeks. Maybe there might need to be laser eventually that needs to be done. But it's a lot of it is reassurance that medication can be given during the procedure that prevents there from being much pain. The procedure is fast. The medication, the treatments that we offer are effective. This is all good news. So I try to let them know that these things need to be done and we need to have this long follow-up, but we can really keep them from losing vision and help them to have a better, more normal life later, with this treatment at this time in their life.
Yeah, I think that was my next question is blindness preventable? And I think that what we have to do and what Dr. Tiffany is doing is helping parents understand, yes, this is going to be a hard 65 weeks, which is about what, 3 months, 3 to 4 months, if my math is right. I don't know, maybe it's not. No, 65 weeks, that's 52 weeks in a year.
Past a
That's
year.
over a year. I'm sorry,
Mhm.
my math is not right. 65 weeks is over a year. So understanding that, but if you can give it that year plus of treatment,
Mhm.
that could save them a lifetime of challenges that could come from diminished or loss of sight. Uh,
Mhm.
and so, because there's statistically people that lose sight or don't have sight have shorter lifespans, right? And we could all imagine what our individual challenges would be without sight. And so, thinking about adding development in a child and all that other stuff without having sight. So there's a lot of things that could flow from that makes that 65 weeks seem really small when we're talking about compare that to a lifetime of
Mhm.
challenges. So I'm sorry, I'm
And
getting
it's
off.
it's so wonderful to see them come back, 3, 4, 5 years later, and then functioning, really well and seeing. And they sometimes do need to wear glasses. That's a question too. There's a
Right.
higher instance of needing glasses in those kids, but it really beats the alternative.
Mhm.
So this question's for both of you. So you both are part of the NICU team, pediatric ophthalmologists, neonatologists, psychologists, nurses, etc. How do you all work together to support families of children who are dealing with ROP?
I think that go for it. Go ahead.
Okay. Um, I kind of mentioned before that we have a whole team and we kind of consider ourselves the psychosocial team, and we meet every other week to discuss families and kind of what their psychosocial needs might be, because sometimes families will share more information with us than they might share directly with the doctors. And so we have an open line of communication. If they're sharing something that we think might impact their care or the way that we serve the family, we're able to communicate those things to the medical team. And then also, one of the things that I'm very intentional about is helping empower parents to be a member of the team. You know, that we, as the hospital, have their prized possession in our hands. But everything that happens, they should know about and they should feel comfortable with. And if they aren't comfortable with, they should speak up. And if they aren't being heard, then there are avenues where they can be advocated for by me or by the social worker. And this is especially important for minoritized people, because oftentimes when they come into a structured system like a healthcare system, especially one that has historically been embedded with racism, there is a feeling of oppression that exists where oftentimes they feel like they cannot speak up or they don't have any power or authority. And so I really try to kind of denounce that and make them feel empowered that you are a part of this team. This situation that you're in is not happening to you. You get to be a part of it. And I think our teams respond pretty well to that.
Yeah, I would say that in our practice, it's a lot of communication. So I feel like everyone has each other's cell phone numbers, and we're constantly talking about the patients. Any patients that are treated, their parents have my cell phone number, and they can reach out and ask questions whenever they need to. So it's about good communication and understanding that we're there working with them.
Mm-hmm.
Absolutely. Well, I was just looking up some quick numbers here, and it says this is from the March of Dimes. In 2022, there were about 380,000 plus preterm babies in the United States. And so when you're thinking about that 10% number that you mentioned earlier, Dr. Charity, you can see how many children that could be experiencing ROP in a given year. And so, and then that child has a family. So you're thinking about how many people are going to be, all of those caregivers are going to be impacted by that. So yes, so in a country of 330 plus million people, 380,000 is not a lot, but when you're talking about the families that are going to be impacted from that and the child itself, the impact it has on the child itself, it impacts a lot more people. So that's why we're having this discussion here. That's why our partners said, look, we're going to talk about retinopathy of prematurity. And so I want to thank everybody that's joined us here this evening and stayed with us as we're really going through this. And y'all are doing a fantastic job. Just want to give you your flowers while you're here. So, all right. So we're getting through the big part of it. So Dr. Granis, what happens when the babies leave the NICU and go home? Will they need to keep seeing the eye doctor? Is that inclusive of that 65 weeks that you talked about earlier, or is it going to be even after that 65 weeks of treatment, they're going to have to see the eye doctor? And if so, how often?
Okay, so if babies reach 35 weeks and their retinal vessels have grown out into zone 3, which is that outermost zone, and they've never had any stage 1 or stage 2 or any type of ROP before they've gotten to that place, they can be finished with exams. So sometimes I'll stop seeing babies in the NICU. There's other kids who, if they've never needed treatment, never had any type 1, or they don't have type 1 ROP by 45 weeks, then, or ROP that does not need any treatment, then by 45 weeks, we'll stop seeing them. So there's some kids who continue to be seen after they've left the NICU. Those that have not yet reached, 45 weeks and don't need treatment, or those that have had treatment and I'm continuing to follow thereafter through 60, 65 weeks. So the kids that go home, we end up seeing them as outpatients. So I'll see those babies every 1 to 2 to 3 weeks, depending on what type of ROP they have and what the follow-up is supposed to be based on the guidelines that we have from the American Academy of Pediatrics. So we'll follow that. And at those visits, the parents come in and I have my technician hold the baby's swaddled. I do the exam very similarly to how I would do it in the NICU. And then the babies go home and we schedule for them to come back again. But usually the offices that end up seeing these patients outpatient outside of the NICU are very familiar with this kind of exam.
Mm.
Mm-hmm.
That doesn't seem like that's, particularly communities of color don't have the best kind of, whether it's real or imagined, track record when it comes to outpatient adherence. And when you're talking about seeing a child every 1 to 2 or 3 weeks,
Mm-hmm.
and having to keep coming back, that could be a bit cumbersome. So I just thinking, from a psychological standpoint, that how do they stay strong in that? So when they're not with you, because we know that most of your health care is happening away from the doctor's office. What are certain things that parents should be on the lookout for regarding their baby's vision and development once they're discharged from the hospital?
So when they're discharged from the hospital, the babies, they're still just blinking to light. They're not tracking. So externally, there's not much that the parents can see or the caregivers can see. Um, but it is very important that they come back for these visits so that we're able to take a look inside of the eyes. Um, it's just so important that those follow-ups happen. Um, and we understand that there's difficulty in coming in that frequently and getting to the office, but we just really need to make sure that the baby's okay before we stop seeing them. But there's not much that you can see, or there's nothing really that you can see on the outside. It's everything inside of the eye that's going on that we're watching.
Okay, so Dr. Gladys, we got to swing it back to you. What recommendations do you have for the NICU team caring for babies with ROP related to the mental health of the parents? And so I know we've been kind of touching on that a lot this evening, but taking it back to what you said earlier in the program, that guilt
Mm-hmm.
and that grief and guilt are really, really big. And so we want to make sure they're on a stable foundation. So what are some of those things?
One of the things that I often encourage healthcare teams or medical professionals in the NICU working with families to consider is, like you said, a lot of what we have been talking about, which are all the factors that are at play for a parent going through a NICU experience. The grief that they're experiencing, the guilt that they're experiencing, the other life circumstances that they're experiencing, what they may have witnessed in the NICU, what they may have been told as far as a projection or a prognosis for their baby. All of that is showing up in who they are when they show up at the bedside. And it's really difficult for us to show up as our best self when we're going through our worst nightmare. And so being sure to give parents grace and to really apply that trauma-informed or trauma-responsive lens in the way that they interact and engage with parents, and really try to see behaviors that might in our flesh be seen as difficult or problematic or overbearing. Try to see them from a lens of what might be going on for the parent, rather than like what's wrong with them or they're just being difficult. Sometimes parents are going through the NICU situation and they've just lost a spouse, or they're caring for a parent with a cancer diagnosis, or they just experienced a house fire. Like, all of these things are real situations that have happened to families that I've worked with alongside their baby being in the NICU.
Yeah.
And so remembering to engage your empathy, because we know that just the same way we talked about the importance of the relationship as a healing mechanism between the parent and the child, the same is true for us as adults to adults. And so if I'm able to engage my empathy for a parent situation and use my relationship in the way that I interact and engage with them, I have the power to change the trajectory of that parent's traumatic or NICU experience. And the same is true in the opposite. When I am disrespectful, or when I don't see or hear a parent, those things stick with them. And I see them years later, and they remember that one thing that a provider did or said, and how it made them feel.
Right.
And so just being as patient and as empathetic as possible to really be a source of healing as they're going through this really difficult time.
This takes me back to a phrase I heard: we report the plane crashes, not the landings. And so, and it's way more landings than crashes, but the crashes are more sensational. So we're going to talk about those bad experiences. We're going to share those bad experiences much more often than we will having a great experience. Now we know that great experience can lead on to having a productive life and a productive relationship with your child and all these great things, but that one misencounter could really derail the emotional success of that progress. So what are some of the coping strategies that you give to parents when they're in this situation, especially after their discharge? What are some at home, because now they're not going to have that team that can come in at a press of a button and the nurse pops up, or you're in there all the time. They're home now, and even when you have a healthy baby, I did that with my children. It was like, you had a healthy baby. It's like, oh yeah, in the hospital it was great. Then you get home, it's like, wait, what? What are we supposed to do? Because they didn't give us the owner's manual when we left the hospital. They just wheeled us out and dumped us in the car. So what are those coping strategies that you give to parents that are dealing with a child that has been diagnosed with ROP?
Yeah, I think one of the privileges and also gifts of my role is that I get to continue seeing families and providing therapy even after they discharge from the NICU. Our babies are seen in our neonatal follow-up clinic until they're about 2 or 3 years old. And so if they are having difficulty to the adjustment home, which is very common, then I can still provide them support, emotional support. So therapy is one of the coping strategies, right? Continuing to process. And some families aren't able to process until they get out of the immediate trauma, because they just are in survival mode while they're in the NICU. Then once they get home, they kind of allow themselves to feel everything that they've been going through. So therapy is definitely one coping strategy, but I often find myself, some people don't want therapy, and so thinking of other alternatives, of ways that they can discharge the trauma that has been experienced in their body. And that looks different for every family, every individual. So really encouraging them and giving them permission even to take care of themselves and to fill their own cup, so that they have something to pour into their baby, their spouse, their family, their job. And sometimes people just need to hear that permission, like, it's okay for you to take a break. It's okay for you to call grandma and ask if she can come over and watch the child. It's okay to, whatever it is that you need to do, stop and get a coffee, or whatever that action is that helps fill your cup. As the parent, not only is it okay, but it is important, so that you can then be what you need to be for that child.
I'm going to speak to the village a little bit. Too often, when you have a death in the family, when you're having to care for, whether it's a parent or a child, the village says, let me know if you need anything, right? Which is so vague and not specific. So I'm speaking to the village members right now. Say, I'm going to do this for you. Be specific about what you're going to do, and then let them tell you if they need it or not. Because if you just say, let me know, that requires so much of that person to be able to not first identify, in the midst of all of this going on, identify a need that they have, and then to be able to verbalize it to you directly. Not everybody is built that way. And so you need to be really, really specific when you're trying to help somebody. If you really are sincere about helping them and giving them that time to fill their cup up, I think you need to be really, real specific. Hey, on Mondays, don't worry about it. I'm going to bring dinner on Monday for you. So, on Monday, I've got dinner taken care of. On this day, I'm going to come by and watch the baby so you can take that walk outside, get a break, go to the movies, whatever you need to do. Give them a specific date, time, activity that they know this is going to be taken care of. Relieve that burden from them of how them having to verbalize to you specifically what they need. So that's just.
And I would add, I think that's beautiful advice. And I would add to that, to the caregivers, to the parents, let the village help you. When they offer, let them help. Because sometimes I think that we get too familiar with struggling, and we think we're just supposed to shoulder it all and do it all on our own. And if we ask for help or need help, it demonstrates some type of weakness in us. And we really need to get rid of that type of mentality, because what it does is it causes us to suffer. So if you are, blessed to have a village and one that is able to help you, let them help you.
Amen to that. All right. So as we're wrapping up here, we've been talking about retinopathy of prematurity with Dr. Tiffany Gladys and Dr. Charity Granis, not related. And we've really been learning a lot here this evening. So what are some resources as we're wrapping up? Because we've given them a lot of information, and they can go on to the blackdoctor.org YouTube page to rewatch this program. It'll also be evergreen on the Facebook page as well. But what are some resources outside of blackdoctor.org that they can tap into to help them if their child is diagnosed with ROP?
I usually have my patients and their families visit the American Academy of Pediatric Ophthalmology and Strabismus for a lot of good information about retinopathy of prematurity and other pediatric eye diseases. So I usually refer patients and families to that site.
For mental health support, I normally point parents in a few different directions. Postpartum Support International is a great organization. If you go to their website, they have a number of different free virtual support groups for parents with different affinities. So if their baby was in the NICU, or if they've experienced a loss, or if they have a special healthcare need. And so that's a great way to get support and be with other parents who've experienced maybe some of the things that you are also experiencing. Hand to Hold is another great organization. They provide one-on-one parent support, also virtually, at no cost to families. And then the Shades of Blue Project, which is specifically designed for birthing people, parents of color, Black moms and dads, and they have some groups as well. And so if you're looking for some mental health support, those are all three good options.
Absolutely. And I just put in the comments for my partners at Prevent Blindness, there is it's a website that has some retinopathy of prematurity, some resources there. There's a link there that you can go to the preventblindness.org site. And then they also have some videos. They have a video series on YouTube that you go to. So that link is to that playlist there on YouTube. You can watch some videos. I know we live in a video generation. So if you don't want to read, they've done the work for you and created a video so you could do that as well. So those are two kind of options additionally to what Dr. Granis and Dr. Gladys have offered up. So there are resources out there. We do have to get out there. Look, if we're going to Dr. Google for a lot of different things, I would say let's go to Dr. Google for things that are really important and find those resources so we can get the help not only that we need, so we can operate from a full cup, but that more importantly for what our child needs, so they can live as fulfilling a life as is available to them, even with a diagnosis of ROP. So last question, and we'll let you go back to your life, is if there's one thing that you want people to remember from this discussion tonight, what is that thing? Or is there something that you missed that you meant to say that you want to get that out now? So it's either something that you want people to remember or something that you meant to say that you want to get it out now. We'll start with you, Dr. Granis.
I think that it's just very important for parents to understand that this disease is something that's absolutely treatable and something that we can follow. It takes some frequency in those visits, but it's very, very important that they come for the appointments after the baby's been discharged.
Adherence to the treatment plan. That's the only way it's going to get better, is a treatment plan, follow it to the T, and then you've got a better shot. Your child has a better shot of having an optimal life.
Absolutely. Mm-hmm.
Dr. Gladys.
Yeah, mine is kind of multi-level, starting with NICU healthcare providers. Just continuing to remind yourself of the trauma. You know, we work in this world, so sometimes we forget just how difficult it can be for our family. So just holding that in mind in every interaction and engagement that you have with a parent, being kind to them, making sure they feel seen, heard, and respected. And in doing that, you increase the parent's capacity to manage the trauma as best they can, and then be all that they need for that baby. So the way that you engage with the parent trickles directly down to the well-being of that child.
Mm-hmm.
Absolutely. So I want to thank you all. I want to thank our partners at the Children Vision Equity Alliance, Prevent Blindness, and the National Eye Institute for putting on another fantastic program with some wonderful professionals. So we'll thank the both of you for giving us your time. We know what your time, an hour of your time is worth, and we should have an idea of what an hour of your time is worth, and we don't take that lightly. My final thoughts are, when I'm going to speak directly to the parents or people that are watching the program. You know, a lot of times, particularly as people of color, we tend to pray. We pray for solutions to problems. We pray for grace and mercy. Well, those things come in various forms. And sometimes it comes in a form of a provider. And you can get all of those things. You can get a solution. You can get the grace and the mercy. What you have to do is you have to recognize it, you have to accept it, and you have to lean into it. We cannot expect miracles. Miracles come in the form of people. They come in the form of professionals. And so sometimes we cannot just sit back and say, well, God's going to handle it. God did handle it. God gave you Dr. Gladys. God gave you Dr. Gladys in order to be able to have your child get the best possible care for ROP or whatever they're dealing with. And so you've got to lean into that, accept it, say, thank you, God, for having these people in your lives, and move forward. Okay, so that is my final thing for the folks that are watching this program. God is here, but He can bless you with people as well, and that's all throughout the Bible. Read it, and you'll see that there. So, again, thank you all. This has just been a fascinating discussion, really, really noteworthy, and I want to thank the both of you for giving us this time this evening. Thank you all for watching. There were some great folks that did drop some comments in there. Go back, rewatch it, replay it, and share it with their friends so they can get that information they need, particularly if they have a child that's born prematurely. Again, thank you, and we'll see you next time.
Bye. Thanks.